Good morning. If you're in New York or US, Latin America, good afternoon, good evening, the rest of the world. Thank you so much for joining us. My name is Sheila Gabea, and I'll be your host and moderator today. Please, I encourage you to just put your names in the chat and let us know where you're coming from. Give us a shout out. If you know any of the people who will be speaking today or anyone you recognize on the screen, give them a shout out. And just some housekeeping. Please mute your microphones if you're in a noisy place or using your computers or your phones. Position your camera as well so that you can see the presentations, and limit distractions. We would love to make this webinar today very interactive. Feel free to ask questions and even ask questions in advance as the speakers today will be speaking. We have a lot of interesting speakers today. Some of them have been traveling to Africa recently, and I'll be telling you more about that. But for now, I want to introduce our CEO and co-founder, Jonathan Stark, to give us a word.
Yes, good morning, everybody. Great to see everyone again. Exciting to have such a diverse group of people from all over. Just wanted to, don't have much to say today because we got a big full lineup. I just wanted to just acknowledge all the people who've been working really hard. It's been an incredible year already. You know, we call it World Vasectomy Day, but that's a bit of a misnomer because we've been doing programs all year long. We've been on a road trip through the heartland of America with Escarguarin and Yeye Cuberos. We've done the webinar now. This is our third one of the year. We were in Uganda training doctors. We have been now preparing for a trip coming right up soon to El Salvador. And we will be soon speaking, we'll be heading back to Zambia, where we're celebrating World Vasectomy Day this year. On top of everything else, the two things that they'll be talking about. We opened up a clinic in Zambia. It's the first World Vasectomy Day clinic with a doctor that was trained by Michelle Lebrecq and John Currington last year. It's going great. Yesterday, they did 22 vasectomies, and it's just been a regular every week. They're doing more and more numbers. I think when we got there in 2023, but in 2022, they only did 7 procedures the whole year. And I think this year already we're up past around 270. So you can see the numbers are growing rapidly as people get more informed, and the program is going to grow there as well. We are going to talk a little bit about, we are always asking for support. Sometimes we get it. Kevin Christie, he was generous last year, and there have been a few others as well. And Doug and NSVI have been supporting the clinic in Zambia. We'd love if more people were trying to raise $10,000. And I'm going to let Sheila talk a little bit about what the clinic is, but that's our hope. We want to raise $10,000 to get the clinic through for the next 3 or 4 months. We need to buy a generator. We need to, the center is not just a center for vasectomy, it's men's health in general, but we're also making it a hub for men. And we are taking the men and inspiring the men who got a vasectomy to actually go on to become part of what we call the Responsible Men's Club, which is an organization made up of men who've chosen to get a vasectomy, who are then prepared, trained, and go out and do their own recruiting and educating within their own communities. And it's going incredibly well, that program, but that program needs support. We pay for their transport, and they have, it keeps growing. We thought we'd get around 10 or 20 or 30 men originally. I think we're almost up to past 100. So that's the powerful tool that we're doing. We need that support. So if anybody can find it in them to give some more, there's ways to do it. You can go online. Kathy will put up the link. But this thing doesn't run on just fuel alone, and fuel costs money in any case. So anybody who can, please give. And Sheila, I pass it back to you. We're just grateful for everybody showed up, especially grateful to Doug again for sharing his knowledge, and grateful for John as well, who is just a stalwart of this program and will be talking about his own work around the world. So Sheila, I pass it back to you.
Thank you, Jonathan. Yeah, I just want to give a little context about our clinic in Zambia. I like to also call it Resource Center for Men. And it's very exciting, not just for us, but also for the community that we are working in. This was not something that was a WVD vision, which it was, but it's also been a vision, as we found out, for the community and for the Ministry of Health. And since we opened this resource center and clinic, we've had a lot of conversations and a lot of input from the government in Zambia. And we are hoping that we can grow this resource center to become a center of excellence for men's health and men's reproductive health in general in Southern Africa. Recently, we've been struggling with electricity, just like Jonathan mentioned, and it's because of the drought, which is caused by climate change. Sometimes people don't understand that what happens in a different continent, the effects could be felt in another continent. Climate change does not just affect one place or one region. Climate change affects all of us, and Zambia has been at the receiving end of the effects of climate change. They've had a drought for the last I'd say 12 months, no rain. When there's no rain, obviously there's no hydroelectric power, and they've been struggling with power. And for that, our clinic has also been struggling with power. And 2 months back, we had power 12 hours a day. Now we only have power 3 hours a day. So we have been trying to get together and get some funding to put together some solar energy so that we can keep our clinic running. We have to autoclave our instruments. We have to keep the work going because we can't close shop because of the drought. But I'm reaching out to all of you, whoever can donate, every dollar that people can donate, UG shilling, Rwandan shilling, the Zambian kwacha, everything that people can donate, we are always very grateful. And even if it's just like sending us words of support, we are really appreciative of that too. Thank you so much for everyone has been giving. And right now I'm going to get into it. And Dr. John Oliotia.
Good morning, Wasuzia Ocha.
Bulungi. So yes, so audience, Dr. John Curington has been performing vasectomies for over 20 years. After graduating from Yale with a degree in linguistics, Dr. Curington worked as a professor for a few years and then attended the University of California, Davis School of Medicine to obtain his degree in family medicine. He now teaches and writes about contraception and reproductive health procedures and practices with Dr. Stein, although he will tell us about his new clinic in a different place in Florida. In addition to his vasectomy practice in the US, Dr. Curington has also performed and taught vasectomies internationally, all the way from the Philippines to Haiti, to Kenya, to Zambia, Mexico, Bolivia, and as of recent, Uganda. And Dr. John is going to be sharing with us his experience of Uganda and last month when he traveled here and did a training in Uganda in July. Dr. John, thank you so much for joining us today. Please take it away.
Thank you very much, Sheila. That's a very kind introduction. Well, I'm going to keep my section of this talk very short because we're here to learn about the difficult vasectomy with Doug Stein. But as Sheila just mentioned, we recently had a teaching trip to Uganda. So I'll talk a little bit about that teaching trip. So basically, this will be a brief summary of our teaching trip. Uganda, as most of you already know, is located in East Africa. There are around 50 million Ugandans. That population has gone up from about 7 million in the 1960s, and the fertility rate is about 4.2 births per woman, which is about twice row placement rate. Okay, so the basic reason why we were in Uganda is because of the great unmet need for contraception. Several organizations there are already doing great work. For example, Marie Stopes International and Reproductive Health Uganda, and we were invited there too. So our goal was to support these great organizations through training. And I'll jump right to what we found out during this training trip. The things that we learned the most was that planning is key. Before the procedures, we went through copious supply checklist, clinic agreements. Sheila and the team did magnificent work looking around to make sure that we had actual spaces within which we could work. Selecting trainees is another key point, trying to figure out who will be good people to teach, who wants to learn, who has talent, and recruiting patients. All of these, in each of these steps, it sounds easy from the outside, but each of these steps cost Sheila so much time and spirit and energy, and she did a fantastic job with all of these. But the basic lessons are that long before any of these trips go on, we have supply checklists, clinic agreements, trainee selection, patient recruitment. All these are important steps of a training mission. Next slide, Kathy. Terrific. So these were the heroes of our trip. We had Sheila Gabeya doing organization, Chiza Blair, and then Zulu Daliso. Fantastic team on the ground. But the more we do these trips, the more we find out that the ground team in advance is probably key for the missions. Next, Kathy. Terrific. So the trainees, choosing trainees, in each trip, it's a bit of an adventure to figure out who wants to be trained, who has the skills to go forth and work after the training. We found 3 fantastic young reproductive health physicians with good dedication, Dr. Rogers Senyonjo, Dr. Chiza Blair, and Fred Chomu. All of them were fantastic trainees. So thank you, team, for having selected these. Patient recruitment was a challenge in Uganda during this trip. We were saved in the mission in the time between patients by the vasectomy model that Michel Labrec has pioneered. In between patients, we use these models over and over again to go over the fine points of the procedure. As you can see from the picture of this model, it is very realistic. Michelle came up with a nice fascia using a special type of tree grafting tape that is very realistic, not only in how it feels, but how it looks. So in between patients, we were able to use these modern models to keep the training going, even though recruitment wasn't as perfect as we had hoped. We still were able to do a good training by doing model practice after model practice after model practice. Next slide, Kathy. We also covered repair of instruments, as we found another lesson as we travel is that we'll arrive in places and find out that, just like was true for me many years ago, many of us don't know how to repair and sharpen our own vasectomy tools. So we had a session in just taking all the tools that were around in the clinics and making sure that the tips were perfect. And as we learn these tricks, I used to use diamond sharpening tools, and now I use sandpaper. I found that different grades of sandpaper, going from coarse to fine, make fantastic sharpening tools. And so we had whole sessions in keeping the instruments sharp, and we worked on the instruments in the clinics. Next slide, Kathy. Thank you. We also covered pack wrapping. As we go along, we find making the physicians able to do the behind-the-scenes work in their own clinics and then teach their staff is fantastic too. So we covered wrapping packs. Next. Thank you, Kathy. Next slide. So in summary, the key points, and I'll be brief because we have many other things to chat about, are for these missions, we're finding over the years preparation in advance, and logistics. As they say in winning a war, it was about bullets and beans. You could say doing a great vasectomy training is a lot about the checklist and ground crew long before the physicians ever get there. So the great team is absolutely fantastic. I have much thanks for Sheila Gabeya and Jonathan Stack, who are making all this possible in Africa. And thank you very much. We'll do as much questions as you want later on.
Thank you so much, Dr. John. As I wait for these people to Please, if anyone has a question, feel free to write it in the chat and I'll read it for Dr. John so that he can clarify for you. But Dr. John, I had a question for you during your training. And as much as it was complicated, I know, like you said, there was a lot of lessons learned. What are some of the things you can tell to doctors who are going on a mission in a country? Because even when you prepare, there's so much you can do. So what are some of the things you think people could have done differently, the team could have done to get more men to do vasectomies? What are just some of the things you think would have made the mission really interesting?
So I think the mission already was, as with your amazing help, really interesting. The things that would have made this particular trip more robust for the trainees would be to have even more patients than we had. Of course, the training is about the didactics and learning theory, but there's nothing like working on lots and lots of patients to make you a better vasectomist. And that, I think, is a trick throughout the entire world to get men to realize how important a vasectomy is. And it goes in cycles. For example, you go to a place, you have good doctors who are well-trained, who do a gentle vasectomy with low complication rate and a low failure rate. And then over the next few months, men talk about this. The media talks about this. It's a virtuous cycle. It's the start that I think is very difficult, as we've seen in many, many countries. Starting that virtuous cycle, I think it's important that we have patience, and that's the patience ending in NCE, to have that kind of patience so that we realize the recruiters on the ground are working really hard, but there has to be a seed for that virtuous cycle. So I would say one lesson learned was it was slightly disappointing to have fewer patients than we would have dreamed of. But in the beginning, starting that cycle is difficult. And I think the whole team learned that you put in lots of hard work, you recruit patients to get a good training, they have good results, because we've done this quite a few times now. And from the seeds that we planted, we hope to have the virtuous cycle continue of those men saying, hey, I had this really gentle procedure. It was great. The doctors were kind and respectful. And from that, they tell their friends, and it makes the next recruiting easier.
Yeah, Doctor, I just want to follow that up with a very interesting question here from Clara. And she asks, will trainees keep a log of their future procedures? And is there a post-training mentoring for the doctors that get trained?
Well, absolutely on both things. For example, I just had a nice email conversation with one of the physicians that we trained who spoke of the numbers of vasectomies that he's been doing in Uganda. And I was absolutely thrilled as he spoke about continuing his vasectomy practice and enjoying using the more gentle techniques. He was already quite skilled before. That was Dr. C. Chomu. And he's continuing to do procedures and doing them a little bit faster and with the more gentle technique. And that type of conversation afterwards, we keep going. We, of course, give our trainees our emails and contact information. And keeping a log, that's up to the individual trainees. But of course, we encourage them 100%, all of us, to keep logs. I keep a log from every single patient I've ever done about any complications so that I know and I understand my rates. And if I make any small change, by following my log, I can tell if a small change resulted in a higher rate of failure or anything like that. So we encourage the young physicians to keep a log. And of course, that's up to the young physician as they go forward in life, but absolutely encouraged. And I think most of us do.
Yeah. Okay, thank you so much, Dr. John. And there's another question here from Covenant. And he asks, how many training sessions is required before the average participant is able to perform vasectomy procedures? Covenant is from Nigeria.
Yes. So that's kind of $1 million question. We have some people, well, I'll tell you an anecdote. I thought I was pretty good after having done 6 cases in a residency. I was not very good, actually. I had a slow, kind of bloody vasectomy 25 years ago. I performed vasectomies that now I would not think are great vasectomies. So you can be fairly competent if you have good hands after just a few and reading a book. However, fairly competent is very different from giving the patient a comfortable, relaxed experience with a smooth vasectomy that has a super low complication rate. So it varies somewhere between about 6 if you have amazing hands and lots of confidence, but you may not be great after that. And many people do quite well after 18. Some people it takes 40. And so there's no single answer for that. But the best answer I can give is that as many cases as you can get under supervision, and then afterwards work with a colleague. We've had good results of people we've trained who for the next few months will work with one of the other trainees, and they keep giving each other advice and feedback and going over the manual and sending us an email and talking about something. So there is no single answer, but many of us have settled on about 18 or 20 cases as being for the average person, but of course there's less and there's more.
Thank you so much, Dr. John. I remember with Dr. Kachacha having never done a vasectomy. I think he did 14 in the week that you trained him. Then he went on to do another 192. And then by today, he's done already 251 just this year. So what you're saying is right. Just keep doing as many vasectomies as you can, and then you get good at it. Thank you so much, Doctor. There's another question here from Prince Jeff Manda from Uganda, and he's asking, is it only surgeons that may be trained, or are other types of doctors considered for training as well?
So the answer is who can do a vasectomy? It's an interested physician. My board certification is in family practice. And we have people doing vasectomies who are urologists, who are family medicine physicians, who are gynecologists, who are general surgeons. I've even worked with a pathologist who is a pretty good proceduralist. So it doesn't matter what your initial board certification is in. It matters that you have the dedication to want to learn, the drive to practice, good skills with patients, good verbicane, as we call it, able to chat with the patients. So there is no requirement for board certification. Now, certain countries and certain regions will have more regulations than others, but in general, your board certification does not matter as much as your training.
Thank you. Carlos Nava here says, it took me around 40 supervised procedures to be able to do them comfortably for the patient. So just like you said, it's really very subjective to whoever is doing them. And Zion Olatunji from Nigeria has a question, which is, I think, a build up to what you just answered, but I think this one was to do with complications. And he asks, are there special skills to be acquired that will help to build competency and prevent complications during and after vasectomy?
Yes, so I think the special skills that are important are appreciation of your own limitations and understanding that too much confidence and speed can get you into trouble. So we try to teach the very gentle, minimally invasive vasectomy. Very rarely you will meet a trainee who has a high confidence and low competence. And that is a dangerous combination. The skill to work on is to have the high competence without overconfidence. To be one of the most important skills is, especially in the beginning, to be able to say no to certain patients. And Doug will talk about these patients soon in his chat, but If a patient is too obese, if the scrotum is too scarred, if the tubes are difficult to find, one of the best ways to prevent complications is, especially in the beginning, to say no to certain patients. As Doug has told me many times, as he's been a great mentor, you never regret the vasectomy that you did not do, the case that you walked away from because you didn't feel like you could do it. You can get into trouble by starting a case that you can't finish. So I'd say probably the main skills to lower your complication rate are humility and understanding your limitations, especially in the beginning.
Thank you so much, Doctor. Veronica Fuentes is asking, I would like to see the training models. Are they made by you, or is there some way that doctors who are listening in right now could be able to access these models that you use?
So beautiful question. If you, and I hope Kathy or one of us could type in vasdoc.org, vasdoc.org in your browser, and there's a section specifically on vasectomy models. There are several vasectomy models that are very inexpensive to make in your own house using very easy household equipment. They're quite good. And with Michel's new fascia that he's created using grafting tape from trees, which you can get on Amazon or very many sources. The new fascia is fantastic, very lifelike. In terms of a realistic scrotum, Michel Labrec is working on and has produced many prototypes now of a very good realistic scrotal model. The trick is getting that into production, and Michel is working very hard on that to get it to be available at cost. So right now, there are several models you can make in your own home that are quite good and work well. If you want the very lifelike, realistic look of the model and skin feel of the model, Michel is working very hard to get a very realistic appearance and skin feel of a model. But already good models exist, which you can see at vasdoc.org, VASDOC. That's Victor Alpha Sierra Delta Oscar Charlie.org for photos and instructions about making very good vasectomy models very inexpensively, and more to come over the next year.
Thank you so much, Dr. John. Oliver Navidio, I see you have your hand up. Would you like to ask a question to Dr. John?
Mine is not really a question. Like when he talked about the numbers, that the numbers were not good enough, it made me think. It made me go back to the drawing board of mobilizing and creating awareness. Because most people out there have the myths. Like they would love to do the vasectomy, but then they are being told, oh, you will not erect, or it will affect your libido, or it will do this and this. So I think if we could also go back to the drawing board and mobilize people, create awareness, use media, and reach out to our target population, I think it would be a good thing. Even in hospitals, when these men come with their women for maybe antenatal, those that have like who are multipara, like gravidate or what, like we could engage the husbands, like we should try to create awareness and get them at any entry point that we can. Yeah, that's all I had to say.
Oh, I think you're absolutely correct. It's about education. It's about getting awareness out. It can be difficult to start that virtuous cycle where 10 men know and they chat with their friends and more media attention comes to it, and then more people have the procedure and then they chat with their friends. But yes, it's all about education and talking about it. And the amazing steps that Jonathan Stack and his whole team have taken about thinking about World Vasectomy Day as a mission to start conversations is fantastic. The more people chat about this and understand, then the more people come for procedures, and then the more people realize that it's pretty gentle, and then more conversations start and the cycle continues.
Thank you so much, Dr. Jed. Also, Oliver, just to add on that, as you know, you know what it's like in Uganda with our culture and our society, usual norms. Getting men involved is one thing, but also it's important for women to want their men to be involved. Because some of the challenges with demand generation or health promotion is in men is not only do we not know as health promoters where to find the men, but also we only promote health to women. Like health is only good for women. We don't teach women that health can be good for men, that family planning can be good for them. We always say family planning is good for you as a woman, which of course it is, because for the longest time we've been focusing on women, but it's for vasectomy and for male engagement in sexual reproductive health and rights. It's important for women to understand that men also need to get involved, because we hear so many women say, I don't want my husband to get a vasectomy. He'll not be a man anymore. So the myths and misconceptions are not just in men, but also in us as women. So as you say, it is a collective effort to get men involved and to get uptake of vasectomy. Thank you so much. Thank you so much, Dr. John. Do you have any final closing remarks?
Well, just thank you, World Vasectomy Day, for organizing all this. And I think as we do more and more missions and get more people involved, we're planting these seeds, starting these conversations, getting more people trained. And it's been fantastic. One of the best joys of my life, honestly, has seeing one of the people we trained years ago now training. It's like a chain, a virtuous chain of knowledge going forward and getting better. People coming up with new ideas, for example, Michelle's new models being built, people training and sharing. So the cycle continues in good ways. And I'll be available after the talk. We should definitely get on to Doug's talk, but I'll be online for any other questions people have.
Thank you so much, Dr. John. That was really insightful. Thank you so much for talking to us and giving us your experience. And for everyone who has asked questions, thank you. And everyone has participated and given opinions. Now, the next speaker is no stranger to many people who are here. At the beginning, I introduced a co-founder to World Vasectomy Day. And I don't know if people ask, who is the other founder then? Well, our next speaker is not only our co-founder of World Vasectomy Day, but is also a board-certified urologist since 1983. And Dr. Doug Stein has focused his practice on vasectomy and vasectomy reversal since 2000. He provides vasectomy services at 17 locations in Florida. And as development director of No Scalpel Vasectomy International, nsvi.org, he has helped develop vasectomy programs in the Philippines, Haiti, Kenya, and of recent, Uganda and Zambia. Thank you so much, Dr. Doug. By a stroke of good fortune, he was discovered by filmmaker Jonathan Stark, our co-founder of World Vasectomy Day, and has played a central role in the vasectomist documentary and at first in World Vasectomy Day. So please, we can't put our hands together, but join me in welcoming our next speaker and our co-founder and founder of NSVI, Dr. Doug Stein.
Thank you, Sheila. You're too nice. This talk is about fingers. I would first like to thank the World Vasectomy Day staff for doing it and for inviting me and for all of you for attending. This talk is about fingers, actually, with some emphasis on one finger in particular, because we perform vasectomies with our hands. And the more we know about fingers and hands, the better we may be at handling those difficult vasectomies. Now, let me see if I can get I like to simplify things. Let me get my images here because it's blocking another. There we go. I like to simplify as much as possible. And as I see it, there are three elements to any operation. Vasectomy is no different. It's how we make it so it doesn't hurt, how we get to our target, and what we do in this case, the vas, when we get there. We administer anesthesia, we access or deliver the vas, and we occlude the vas so that sperm don't pass through it and get girls pregnant. And there are different options for each step. The question is, which options are the best? Now, you could use needle anesthesia and make an incision with a knife on both sides. Heck, mine was done this way 35 years ago, and it worked great. Still have the scars to show for it. Or, like, for example, Doran Boone and some of our colleagues in the UK, you can make an opening with a cautery unit. You can watch his and other very elegant vasectomies on vasdoc.org or on the NSVI website. So, as seen in these photos taken at the time of vasectomy reversal, this operator at the top used 5 clips on each side. And this operator used nylon sutures when he did his patient's vasectomy 2 years ago under general anesthesia. Both patients ultimately did fine. First and foremost, don't cause pain. And try to choose a technique which in your hands has few complications and few failures, because pain, complications, and failures give vasectomy a bad reputation, and it spoils it for all of us. There's always room to learn, and you may become more efficient with time by adopting other people's suggestions. Developing a technique that works for both easy and challenging cases, like obesity, prior scrotal surgery, in this case, a vasectomy reversal, and in this case, an orchidopexy for cryptorchidism that didn't quite bring that testicle down, or in this case, a cremaster muscle reflexes that fight you every step of the way. Your patients will never complain that you didn't spend enough time performing their vasectomies. They may complain about their other doctors not spending enough time with them, but they won't complain about you. They want to be in and out as quickly as possible. So minimize your movements and get it done. Now, I've never used general anesthesia for vasectomy. I happen to like use of the spray applicator, but I use needles pretty frequently, and they're great. They work just fine. For occlusion techniques, there are varieties of things. I don't do a traditional vasectomy, just an NSV. And the occlusion technique that I like the best is mucosal cautery and fascial interposition. But that's the subject for a whole another webinar, which occlusion techniques might be best. I've divided access and occlusion into 3 phases and a series of steps performed in only 2 positions. By dividing the process into steps, trainees get into a rhythm that is easy to remember. But the most difficult process to learn is right there. Phase 1, getting the vas into the ring clamp. It's 90% of the learning curve. Now, John talked about who does vasectomies. Well, over 75% of the providers who visit me in Florida have little surgical experience, but they want to learn. Why do we do vasectomies? Well, some want to earn more money. Some are advocates for women, some for children, some for the environment. But it seems to me that everybody who visits me wants to use his or her hands. For many humans, their hands are their livelihoods, not the lawyers and the insurance salesmen, but many people make their living with their hands. My father was a machinist, and he had the deepest respect for his hands. And he said, Doug, you ought to be a surgeon. In fact, he wanted me to be a hand surgeon. My mother wanted me to be an eye doctor because it's kind of clean. But instead, I became a urologist monkeying around with penises and scrotums all day, and they thought that was kind of a ridiculous choice. But anyway, while much of vasectomy is eyes directing hands, Phase 1 is hands only, and that may be why it's the most difficult phase to master. Like playing a guitar or a violin, vasectomy requires good fingertip sensation, motor control, and strength. In other words, good hands. In fact, what sets humans apart, I think most people would say, is our hands and our brains. Our hands and brains working together led to advanced tool making. Our hands are our tools, used primarily and to make other tools that extend their abilities even further. Now, what's so special about hands? Well, I'd say structure, and I guess you could give credit to structure and innervation. The fossil record shows that Homo erectus, so-called because he walked upright, as you know, not because he had great erections, had hands as developed as our own nearly 1.5 million years ago. It wasn't until about 300,000 years ago that Homo sapiens, man wise, developed a brain capable of maximizing the potential of those hands, perhaps contributing to the extinction of other human species that had similar hands, and leaving us with hands quite different structurally from all other species, but with strong fingers, thanks to our brachiator ancestors. The innervation of our hands is also very special. Our hands are loaded with sensory receptors of many types, the most important of which may be Meissner's corpuscles. Because Meissner's corpuscles can detect skin indentations of less than 10 microns, surely bigger than the thickness of a vas deferens. And in contrast to other primates, only humans have complex lobulated Meissner's corpuscles. So, no, you probably can't teach a monkey to perform a vasectomy. All of this information coming in from all of these receptors has to be processed somewhere. Where? Meet Cortex Man, representing how your brain sees your body. Your brain is really dedicated in large part to your hands. Yet, compared to his hands, even his treasured little unit down here doesn't get much brain space. And just look at that left-hand position. It almost seems like Cortex Man was made for that three-finger grasp of the vas. So let's take a look at the brain now. Just behind the median sulcus is the sensory cortex. Now, seen on coronal section, look at how much of the sensory cortex is dedicated to hands and face. Heck, if you look right here, you'll see that there's more cortex dedicated to the middle finger than there is to a man's entire package. Not only that, but this brain tissue is dynamic. You can invest in it. MRI studies show increased cortical representation in the left-hand fingers, not so much the thumb, but the left-hand fingers of string players. Why? Because they're always using their fingers. Again, not so much thumb, because it's less important for string players, just providing a source of support for the neck. And it turns out that the amount of cortical reorganization of the fingering digits correlates with the age at which you start to use them and develops depending on their repeated use. So it stands to reason that as we do vasectomies, our sensory cortical tissue for our fingers actually reorganizes as we use them. More so for players who start early in life. That doesn't mean getting your 15-year-old daughter to come into the office and start doing vasectomies early, but the earlier you start, you may have a bit of an advantage. So start early and practice, practice, practice to develop those pathways. Now, for motor control, we've discussed sensation. For motor control, Motorman is even more impressive. You can see in addition to good sensation, you need motor control to position the vas, and the motor neuron representation is even more impressive. Not only are our mouths and hands well represented from a motor standpoint by the tissue anterior to the median sulcus, as you would expect in the only species with complex speech and tool-making ability, but the motor cortex actually gets some help from the premotor area and from the cerebellum that fine-tunes our skills to produce movements so fluid and harmonious that we're not even aware of them. Some call it muscle memory. So when you forget whether you've already done the other vas, you probably did it with your cerebellum on autopilot. So again, start early and practice, practice, practice. Now that I've patted us all on the back for having such great sensory and motor equipment in our hands and in our brains, we need to develop some strength. That's number 3, to tackle those difficult vasectomies, but strength with control, quiet hands. I like to pretend that the patient is taking a nap and I'm trying not to wake them up. And a lot of pulling and hand movement is going to wake them up. In other words, the fewer the strokes, the better, just like golf. So, try to use your hands only. Start by relaxing your upper body, elbows tucked into your sides. Heck, that's why we emphasize palm up for your ring clamp, because when you're palm up, your elbow's into your ribs. Rotate to palm down, and your elbow is flailing way out to the side. Stabilize your hands by resting your forearms on the patient. He won't mind. In essence, pretend that your patient is your pool table. Now, look at how these expert pool players stabilize their hands, and by extension, their instruments. This pool shark even puts his instrument right on the table. So stable, you really can't tell how many beers he's already consumed. By contrast, this player is a little shaky, but she has a good coach, and there's still money on the table for more practice games. This patient is my pool table. The entire weight of my right hand, now I'm left-handed, so bear with me on some of these pictures, but I'll convert to right-handed in a minute. The entire weight of my right hand and forearm are on him, in fact, on his pecker, and he doesn't seem to mind, so that I can devote my entire attention to the Meissner's corpuscles in my fingers as I feel for that elusive vas, thin, encumbered by scar, whatever. Once found, I wedge the vas between my thumb and my second finger DIP joint, and then I give the vas the middle finger. Then I roll my hand away from myself without ever lifting my hand off the patient. With that middle fingertip, I'm trying to push the vas to the front of the scrotum, right up to the surface. And to prevent a drop, my dominant left hand comes in to prevent the vas from falling off my middle fingertip while my right thumb fine-tunes the position of the vas under the skin. If needed, I can shift the skin forward and back with that assisting non-dominant hand. In fact, my MetaJet hand is also palm up. You can't quite see it here, which brings that elbow into my ribs for more stability when using that. Shown in cross-section, you drop your thumb straight down toward the rectum to completely encircle the spermatic cord. Then slowly and meticulously massage the cord until your Meissner's corpuscles detect something a little thicker and a little stiffer and a little rounder than everything else, like al dente spaghetti surrounded by overcooked angel hair pasta. Your motor cortex goes into gear to help you tuck that vas into the crevice of your second finger DIP joint, while the other elements of the cord slip away posteriorly. Then the middle fingertip engages the vas and pushes it medially and anteriorly right up to the surface of the scrotum. This is where the strength comes in. This is where you need to hold the vas between your thumb and your middle finger while your dominant hand reaches for the ring clamp. This shows a mid-finger or palmar grasp with the vas kind of between the flat surfaces of the thumb and the middle finger. Now, I have trouble retaining the vas in this position. It seems that I drop it more frequently. Because it seems that I don't get enough strength, which makes sense, because with that teardrop position, I'm only using my flexor digitorum superficialis to bend this joint, and I'm only using my flexor pollicis brevis to flex this joint. But if right now you try this, squeeze a fingertip of your opposite hand with a teardrop hold. Now roll your fingers into an OK sign and squeeze as hard as you can. See the difference in power? Why? Because you've doubled the muscle. You're now using 4 muscles, the original 2, plus now you have recruited the flexor digitorum profundus, which does this in your forearm, and the flexor pollicis longus, which does this and bends your thumb. So, repeating the prior slides, the vas was engaged by the middle finger and pushed medially and anteriorly to the surface of the scrotum. Now you can squeeze hard enough to press the vas into the pulp of your fingers and never drop the vas again. Because I'm using my fingertips, I've given the vas a finger directed at myself. The same applies to the ipsilateral side, only now you're giving the proverbial finger to your assistant across the table. No one likes to drop a vas. It wastes time. These are my hands, left-handed. Now, you're probably getting tired of my left-handed photos. So let's switch to right-handed. There we go. The dominant hand, your left, if you're right-handed, the dominant hand keeps your right, if you're right-handed, keeps the vas from falling off the middle finger of your non-dominant hand, while the thumb fine-tunes the position of the vas on the tip of your third finger. Then the thumb locks on, which brings me to the next virtue of our human hands. We have pulp. These beautiful little corpuscles of fat then can selectively flatten in response to pressure, which means you can squeeze hard enough to press the vas right into the pulp of your fingers and never drop a vas again. With the vas embedded in the pulp of my fingertips, I won't drop it while I'm engaging it with the ring clamp. That's easiest if the vas is pushed way up just beneath the skin with the pointy tip of your third finger. I actually think of my middle finger as the center pole of a circus tent, with the vas draped over it, while my fingers here are pushing down on the surrounding skin as the stakes of the circus tent hold the tent margins down. So to get that vas into the ring clamp is the most difficult step to master. In summary, use two hands. You've got two. I think if I had three, I'd use three. Give the vas the finger by pushing it out of the scrotum with the pointy finger tip. Lock on to indent those fatty corpuscles in between your thumb so that when you're reaching for your ring clamp, it doesn't fall off your middle finger. Open that clamp really wide. So with the tip of that finger, you just have to gently push, and that vas, you can even tickle it a little bit by wiggling your finger. And that vas will just float up into that ring clamp. Now, if it doesn't, because the skin is really thick, or the vas is really thin, or there's a lot of scar tissue, as long as you can feel the vas, open the skin if that makes it easier. Heck, I open the skin about 30% of the time. And when you open the skin, then you can go on to dig pockets on either side of the vas with your NSV dissecting clamp. You're digging these pockets so that you don't have to push so hard to get the ring clamp to just fall down while you tickle it from below with with the very tip of your third finger bent up by your flexor digitorum profundus muscle. Now, I've only gotten through phase 1, but that is the most difficult part of the NSV process. And some of the concepts may help with those, and some of the concepts which I presented may help with those difficult vasectomies. The rest is done under direct vision and easier to learn from all those videos that are on nsvi.org and vasdoc.org. Now, I'll show some videos that I made in preparation for this talk, but let me first summarize and then open it up for some questions, because I think technically we're out of time, but I'd be happy to stick around if people want to see some videos. So in summary, feel privileged that you have such wonderful tools at the ends of your arms. Every vasectomy is an investment in your sensory and motor cortices. And remember to give every difficult vas the finger. Thank you.
Thank you so much, Dr. Doug. I've just been hooked learning words that I've never heard before, but I'm sure it's been so easy for everyone who's been listening, because most of the people here, most of the audience is doctors. We already had a hand up while you were presenting from Owumugisha Teasin. If you're there, Owumugisha, would you like to unmute, please, and get right into it with Dr. Doug? Dr. Esgar Gwarin, welcome. And
Hello,
then
everyone.
Hello, please go ahead, doctor.
Thank you so much, Sheila. I'm going to use a word that my wife just used with me. I was just commenting with her during the talk, and I was trying to find a word to explain how I was feeling about this talk that Doug was giving. And forgive me, I don't want to seem like I'm, praising unnecessarily Doug, but he knows how much I care about him and how important his guidance has been for me for many years. So I was struggling trying to describe this because I've seen you give a similar talk in the past. I've received directly your guidance on this, but my wife found the right word for how you presented this today, and it was poetic. That's the adjective she used. It was poetic, and I couldn't let it go. I had to tell you that. It was an expression of the tremendous love you have for the procedure and the respect that you have for the procedure, how much you think about it. That technique, that whenever patients ask me, so how is it that you guys do it? I naturally show them my hand and naturally do the okay sign. This is how you do it. And that's what I tell them. And that's because of what we've learned from you, Doug. Thank you so much for this talk. I wanted to compliment you because, she described it perfectly. It was poetic. Thank you so much.
Thank you,
It was good to see
Thank you, Escar.
Thank you so much, Dr. Escar. I completely agree with that. It was just nice, and it was so everyone I'm sure was very attentive because you have all the jokes you put in and all the other things you talked about. I saw somebody else had their hand up. I don't know if it was you, Mandy. Somebody put their hand up and put it down real quick. I think it was you, yes.
Mine was just clapping, and I can only reiterate that, Doug, you are a gift, and we are seeing this group of people together internationally and knowing that you are sharing your knowledge with all of us. And I can say I pass it on to every trainee in all of the states that I've started programs. But hearing you describe leaning on the pool table and giving us the words for our trainees is really a skill. And you have passed it on. You have achieved your goal of giving us what the world needs to be better. So thank you.
Thank you, Mandy. It was fun. It was fun preparing it. I kind of learned a little bit myself.
Yeah. Dr. Doug Ziwase from Zambia says, thank you so much for taking us back to anatomy class. These are medical students from Zambia.
That's what it's all about. That's why we took anatomy.
Okay, just please, people, feel free to put your hands up, but there's a question here from Brandon Chase. Can you explain how you transition from using two hands to stabilize the vas to using one hand so you can grab the vas clamp?
I think the most important thing there is to just lock on. If you're using two hands, let me use it right-handed. Well, I'm wearing a mirror image, so it probably doesn't matter. But I would ask you right now, while you're sitting there, to go like this, bring your thumb over and grab the vas, take this away, put this back, lift your thumb, put it back, take it away, and do that repeatedly. Now, your vas is either being held by your thumb or by your other hand keeping the vas from falling off your fingertip. So when the time comes to use this hand to grab your instrument, now you really have to lock on. And the best way to lock on is like that, with a big, strong OK symbol grasp, because that is going to embed the vas within the pulp of your thumb and your third fingertip. So that now when you come back, you're just sliding your thumb just a little bit back and you're reaching in with that ring clamp and grabbing that vas on the tip of your third finger while your thumb is naturally still holding it. But eventually the ring clamp is going to be on either side of the vas so that you can kind of release your thumb, and the ring clamp itself will keep the vas from falling off your fingertip.
One final comment from somebody, Paul in Uganda says, thank you so much, doctor. You made me remember my neurophysiology of year 2, pre and post motor cortex of the brain. Thank you so much, doctor. At this point, I'd like to come to a close. Dr. Doug, I think if people are willing to stick around, you can share some of the videos
Okay.
because I know some of the people want to watch what is in the videos.
Okay, let me see if I can share my screen again, and I'm going to, there is my video. So when I play this, the audio of the video should come through on your computers. If I want to interject anything, I'll just hit pause because that will stop the video and I won't have to talk over the video. So let me hit play, and if anybody has trouble seeing it, raise your hand or whatever. But I'm going to explain some of the things that I explained in the presentation that I made, but I'm not very good at embedding videos into presentations. So this is why they're independent. So here I've got the VAS in position. I am holding it between my thumb tip and my second finger DIP joint and bringing my third finger on it. And now I'm giving my third finger to that VAS. Now, this patient is not a difficult vasectomy, but you can see that in this position, I'm sort of pretending that my third finger is the center pole of a circus tent, and I'm pushing all of his skin aside so that his VAS comes right up onto the very tip of my finger, which is fairly pointy. The MetaJet goes down onto it, 3, 2, 1, and pops a little in. Now, if I was going to do his vasectomy at this point, and you'll see that in a minute, I would grab it also with a ring clamp. Now, this patient isn't prepped naturally because when you're using a spray applicator, you're using the spray applicator before the final prep. But if I was using needle anesthesia, I would have the patient all prepped. And at this point, I would just use my mini needle to add a little bit of anesthesia to the skin and to the underlying VAS. I think the experts with needle anesthesia anesthetize one side, then anesthetize the other side, then go back to side one. But I wouldn't see any harm, I don't think, but I would be interested in the comments of needle anesthesia users if there's any harm in just injecting skin and then VAS and bingo, just going right to the vasectomy. Let me finish this. Okay. Now, let me close out that video or find my second video here. And this is on the MetaJet side too, because without the drapes, you can see my hand position a little bit better. The right side, I'm doing the exact same maneuver. I actually meant his left side. Wiggle the VAS between my thumb and my second finger DIP joint. Now I'm going to take that third finger and I'm going to give this VAS the finger too, bringing it way up toward the very surface of the VAS. You can even see his VAS rolling. I'm bringing it to the exact same spot that I did the other and this VAS. Now here I'm locked on. I'm really holding that VAS tight with you can't see how much energy I'm putting into my thumb and third finger, but it's a lot because I no longer have my left hand preventing the VAS from falling off the tip of my third finger. Is right on the tip of my finger. So in other words, I'm like this. This is an okay symbol. The alternative way to hold the VAS into position, let me get a little bit of lidocaine here, 3, 2, 1. The alternative way is with what I call a scissors technique of holding the VAS. And you can see that I also call this kind of a mid-finger hold. You're holding the VAS on the middle portion of your third finger, holding it back with almost the mid portion of at least the distal phalanx of your second finger. You know, I can't get tough ones like this, and so I'm a fingertip guy. I like holding the VAS with my fingertips rather than the mid portion, but I've seen many doctors do very elegant vasectomies with this technique. So if you're more comfortable, go with what's comfortable. I just can't do the difficult ones like this. So because I need that OK symbol to really apply the power to the difficult VASs, I think I eventually do everybody the same way. A lot of very good vasectomists hold the VAS like this. In my case, I just can't quite feel it as well as I can with the very tip of my fingers. See, this I call it a teardrop configuration of my fingers. So I don't know what viewers here are using for their own, but I do much better if I'm in this OK symbol and then bringing the vas up toward the surface as though on this side, I'm giving the person across from me the finger. And there we go. Okay. Okay, and now I got another one. If I can, if anybody leaves, that's okay. If I see the participant numbers going down, that's fine. I know we're using up a lot of your Saturday. But this one is the actual vasectomy on side one. Here again, there's my vasectomy spot where I use the MetaJet driving. The fingertip maneuvers are really the same for anesthesia with a MetaJet. And now this person might not have any anesthesia if I were using needle anesthesia. My thumb right down for the posterior portion, just gently massaging the spermatic cord. Remember, I'm trying to pretend the patient is taking a nap and I'm trying not to wake him up. So I'm not yanking up with my arm like this. A lot of initial vasectomists think they got to pull and pull and pull. This isn't a pulling operation. This is a pushing operation. Until the vas comes between my thumb and my second finger DIP joint. Third finger rolls around, and now I'm giving the finger to this vas. Again, this is not a difficult patient, but he's a good patient to illustrate this. Now, the tip of my fingernail is right here. This is the very tip of my finger. You can see this OK symbol configuration here. And when I get the vas in that position, when it comes time to use the ring clamp, I can simply tease the vas with the very tip of my third finger until I can feel it. So I'm just teasing it, not with this portion of my finger, but with this portion of my finger. And I hardly had to push. Now, this is a pretty easy patient, but I hardly had to push because I opened the ring clamp wide enough. Most people start out and they don't open the ring clamp wide enough. And if you open it wide enough, the vas will just float in. The vas will just float right into the ring clamp. Here I want to demonstrate how I'm using all 5 fingers. I'm using this finger. This is a platform. I'm pretending that he's the pool table and the weight of my upper arms is on him. We're going to try to do this in one poke and then one spread and then one hook and then one grab. Now, what you just saw was access. That was phase 2. First phase is ring clamp. Second phase is access. One poke, one spread, one hook, one grab. Should take, if you're getting some practice, less than a minute. And that, I think, demonstrated that you can take less than a minute. Now, I haven't done a vasectomy yet. Now we're on to phase 3. Try to emphasize to people who come for training is to do the rest of the operation. And we haven't done a vasectomy yet. All we've done is deliver. Their whole vasectomy is done in second position. And by that, I mean that I'm using my index finger as a platform. So once again, now I'm giving this finger to the difficult vasectomy. And by maintaining myself in that position, it gives me a lot of stability. The vas is not kind of shaking all around. It's stabilized the entire time. You'll see that I'm still in second position. I'm still in second position. I'm holding the skin back so that I don't have to worry about pinching the skin when I pinch the fascia. I'm rolling around 180 degrees. I'm still in second position. And here you can see that if I like this to be sort of an equilateral triangle from here to here, same distance from here to here. If I find that this abdominal end is pointing out a little bit, I'm going to bring that thumb in, migrate that up just a touch. you can see here by pushing this back, I'm creating a thinner apex here. Notice I'm using this finger, these two fingers, my index finger, and my thumb to stabilize the vas. I have not come out of second position. Here I'm going to prepare a hemoclip. And then my index finger actually helps me guide that hemoclip very accurately onto the tissue, the fascial tissue that I'm trying to close. And here again, it's still a nice background where I can push against it, even milk that abdominal end a little bit higher so that I get excellent end separation. And so the ends are separated both spatially and by a tissue layer. Here, if that hemoclip did not go all the way across the fascial interposition tissue, it's easy enough to bring a second clip in just underneath the first, so that now the two clips are kind of like this and really securing that fascial closure. Now, all that said, if you're using ties, as I'm sure most of you probably are, rather than hemoclips, especially the folks in African countries and maybe some of South America, you may not have ready access to hemoclips. And so you do have to come out of second position. And all you do is simply drop the hemostat that holds the sheath tissue together for your fascial closure, and then drop that down and then slide your silk or Vicryl stitch underneath it, tie a knot down onto it, and then you get the same end result as you have with clips. And I don't have to worry about a slide back or anything. We've got great end separation and fascial closure. And he's all set to go. Now, on one final video, it's the ipsilateral side, and I'm going to demonstrate something that's a little bit, because on some of the ipsilateral cases, they can be very difficult because of a tight scrotum. For a difficult ipsilateral side, you can see that I could grab the vas like this with my thumb, but notice which is a better hook. This is a much better hook than this is, because it has two joints and it's not as curved backwards. So if I take that and I go down and just hook the vas and bring it forward, now I can use that third finger. Again, I'm giving the difficult vas the finger, holding the vas between my index and right thumb, bringing my vas up, and then grabbing the vas like that. It just slipped off while I was demonstrating. So here again, I'm rolling that, bringing my thumb into position, and there I am with the vas right on the very tip of that third finger. So now I'm sort of giving the finger to the person across the table from me, whereas before I was giving the very fingertip here. And now I'm just looking down my ring clamp like I'm looking down the barrel of a gun. The very tip of that finger is tickling that left vas into that ring clamp. And once again, the rest of the procedure is the same. My index finger never leaves that spot. I'm holding this down, and my index finger serves to bring the skin above down, so that then. Now I'm pausing for just a second here, and I'm saying to myself, how do I want this vasectomy to look? I'm imagining in my mind what would be the ideal, because I think if I take just that second to think about that, it's more likely to happen. And my goal is one poke, one spread, one hook, one grab. I don't always do it. I can't always do it in less than a minute, but it's my goal. And I think if I step back and I think about it for just a second, it increases the chances. I can right in and cannulate that vas like I'm trying to start an arterial line. Two tips, I may have been a little bit off at the 11 o'clock side, but I think we're in pretty good shape. Let me do a little bit more of a spread there. And then just poke the vas. And if I rotate my wrist back and down, it should come up nicely. Again, at first I was a little bit off on the 11 o'clock side. So I'm just going to do that one more time now. Did you see that? I failed to get it with one poke, one spread. And so now I got to go back and do a second poke and a second spread.
Second grab, vas comes up. Here I'm a little bit more in the middle. Spread that internal spermatic fascia. And now
You might be able to see that these are one of those NSV dissecting clamps that John has sharpened. See your sharpening marks on it, John? It works great.
the vas will deliver more easily because I've gotten through that last fascial layer. Once again, right into second position. On this side, I have a little bit of what I call an apron, which means I have a little bit of fascia left over, but second position stabilizes the vas so that then I can use my pointy hemostat.
I want to emphasize that I was not ready to proceed. If you've got an apron of tissue coming up like this, don't go poking into that. There's too many vessels into it. You are not ready to complete your cauterization, division, and fascial interposition until that vas is totally independent of its surrounding support tissue.
To go through that one final layer and just bring that now naked vas up. And now it'll slide out much more easily. You can see that before, when I had an apron, it looked like this. I was holding on to some fascia, but now you can see a dimple. So if you have a dimple, you're ready to go. A little bit of a dimple on this side. This is an apron. It comes up like this. You're not ready to isolate the vas. But here with dimples on both sides, I can just come right through with isolate. Those 4 steps of the vasectomy: isolate, cauterize, divide, and separate. So there's isolate done. Here's cauterize. Here's divide. And the separate is merely the fascial interposition, pushing the abdominal end in. Still in second position. Notice that second finger has never changed its location. It serves as a nice way to do a little bit of a tear back and increase the distance between those two. If this comes up, I can migrate it a little bit. Now, let's say that you're not happy with your fascial interposition and this end is poking through.
In other words, this is fairly well covered, but let's say that it's poking through even more and you want to cover it more effectively, and that is get better fascial interposition.
In his case, it's really not. But if I want a little bit better fascial coverage, simply grab a little more fascia, bring it up like this, and now see the beauty of this. With 5 fingers, I'm using my 5th finger to hold this back. I'm using my index finger as a platform, and I'm using these 2 fingers and my thumb to hold 2 instruments. So I'm holding 3 instruments with one hand, and it's giving me the ability to enhance my fascial closure by bringing up that layer. You can't even see the abdominal end now. It's so well covered. And then laying in that hemoclip.
Now, once again, if you're a suture user, you just lay this down and you lay down your instruments, and then you just loop your suture behind there and tie a knot directly down where that hemoclip is. So I probably should have had a demo video with suture to do that, but John, maybe we have John has an excellent one, by the way, on vasdoc.org. You can see John Curington, because John always uses suture, and you can see him doing.
Hey, Doug?
Which is not going to fail. He's got 2 centimeters of end separation. He's got
Almost
beautiful
done.
fascial coverage. And I can't imagine this thing growing back together again. So I think we're good. There's no bleeding. I didn't use an extra clip on this side because I've got tip-to-tip clip approximation. And he's good.
I'm done.
But we'll just let everybody, because it is Saturday and we want everybody to to get on with their lives and do all the cool things that you need to do and enjoy yourselves and relax. I do want to make a final appeal to people. We're going to be sending you out the video with an appeal video for support. I know some of you have no money and we don't expect. Others of you might be able to support the project to get to that $10,000, so we're able to keep that clinic going in Zambia and create the Center of Excellence. I wanted to thank you again, John, for the work, and of course to Sheila for hosting the evening. I'll pass it back to you to close out, but you know, Doug, as always, what a honor and privilege to work with you. Your passion for this work is why we're still here today. And who would have ever believed I'd be spending my Saturday morning looking at Vaz, but thank you for that. And thanks everybody for coming today. Stay in touch. World Vasectomy Day is coming. It's around the corner. We'll be in Zambia. I'll be going there. Doug's going to be there. Michelle's going to be there. I think John is going to be in Argentina. You know, we have room for more people, not maybe now, but in the future. If you're interested in joining a mission, let us know. We want to get you prepared so you can have a great experience. Like, we don't want to just keep it to these few guys, but and now we have Luisa coming to a few locations as well. So the movement is growing. We really appreciate everybody showing up, and we'll be in touch with everybody. And Sheila, if you give you the final thoughts.
Thank you so much. I wanted to encourage everyone. I know there was so many other questions that people didn't get a chance to have them answered or even ask them. Please reach out to us and we'll forward these questions to both Dr. Doug and Dr. John, and then they'll be able to reply to you. Our next webinar is November 16, and it will be held in Zambia, where Dr. Doug will be with Dr. Michelle, and it will always, as usual, be also hybrid. So we look forward to seeing you there again, and we'll be letting you know what the topics will be on the next webinar. Others, thank you so much. You'll be receiving the email after this, which has all the presentations from the two doctors. Thank you so much. Have a great Saturday wherever you are in the world, and stay well, all of you. Thank you so much.
Bye-bye, everybody.
Bye.